otolaryngology at UT Southwestern, and we're going to be talking about acoustic neuroma. So Dr. Kutz, thank you for joining us.
Well, thank you for having me, Kristen. I'm looking forward to our discussion today, and I hope everybody's doing well and staying safe out there, wearing your masks.
Exactly, yes. And we are obviously not in the same studio. We're practicing social distancing. So, I mean, just to get us started, I mean, how has COVID-19 and the coronavirus impacted your clinic, your specialty?
Yeah, you know, when this first started in March, actually our clinics pretty much shut down for about 6 weeks. You know, we weren't sure about the PPE. We weren't sure how we were going to have a big surge in Dallas. Unfortunately, we didn't have a surge then, although the numbers have increased recently. And so really we were seeing no patients unless it was urgent. And so patients with acoustic neuromas that would typically be scheduled for follow-up MRIs, we actually delayed those MRIs and follow-ups until about probably late April, early May. And now we're seeing patients again. The other thing that's changed, we're doing more telehealth, which actually has worked really well for patients that have an acoustic neuroma or that were treated with Gamma knife. And all they need to do is discuss their MRI findings and their care. I don't really have to do an exam. So we've done a significant amount of telehealth, which has been great.
Interesting. So with, you know, I know we talked about this a couple years ago, but what are some of those, you know, early symptoms that can be overlooked or missed, particularly now when maybe people are not leaving their house, they don't want to go to the doctors? What are those early symptoms?
Yeah, I mean, most acoustic neuromas are going to present with hearing loss in one ear. It may be a sudden hearing loss or gradual hearing loss. And most people, when they have a hearing loss in one ear or even both ears, I think maybe it's just allergies, they have fluid in their ears, which is very, very common. So oftentimes you may have this hearing loss, go on for a while, you see a doctor, maybe diagnosed with an ear infection, give an antibiotics, it doesn't go away, and then you see an otolaryngologist or an audiologist that is a hearing test, and then your hearing loss is actually not from fluid, but it's an inner ear or a what we call a sensory neural hearing loss. And if that's in one ear, we always recommend an MRI because there's a chance you could have an acoustic neuroma. And realistically, that chance is probably on 1%, but anybody with unilateral hearing loss needs an MRI, and that's the most common complaint. Sometimes you may develop ringing in one ear. Sometimes you may get some chronic imbalance. But as a matter of fact, most patients we see with acoustic neuroma probably had no signs of it. They had an MRI for something like a headache or something of that sort, and they had an incidental acoustic neuroma found. Okay. So it's pretty tricky, and sometimes there may not be any symptoms.
Okay. So how do you decide, you know, once somebody has that diagnosis, how do you decide how to move forward? I mean, what are some of the considerations that you do now?
Yeah, it's, you know, the first thing I tell patients, this isn't, it's not a cancer, it's not a malignancy that's going to spread, it's not something you have to immediately treat. And so you really have time to sort out, you know, what is the best treatment option for you and think about these things. And frankly, the majority of tumors we just follow now, and we'll have an initial diagnosis, and then in 6 months, they'll repeat an MRI. Oftentimes the tumor is not growing, and we'll just follow the tumors every year. And a small tumor in an older patient, you know, about half those don't really grow. And so I think over the years, we follow more and more of these. Other factors, you know, very young patients, very large tumors, those are the tumors that probably need surgery or treatment. As we get older, since these are such slow growing tumors, and like we talked about, may not grow, oftentimes we'll follow them. So one thing that makes this interesting is that every patient is very different, right? There's all these different factors, and because it's not a malignancy or anything that's truly urgent, the patients have a lot of choice in their treatment. Okay. Which is nice.
Gotcha. And so, what are some of those treatment options? I feel like I've seen, you know, cochlear implants could be options. I mean, what are we looking at today?
Yeah, I think for the treatment of the tumor, there's really 3 options. You can observe the tumor, which I mentioned we do for many of the tumors. If the tumor enlarges after an observation period, then we would treat it with a radiation modality called Gamma knife radiosurgery. It's very well tolerated. The patients come in that day. I work with a radiation oncologist. We treat the tumor with one-time radiation treatment. It's done by noon. Most patients have very minimal to no symptoms after treatment. And then it's about 90% successful at stopping the tumor from growing. So probably less than 10% of the time, the tumor could enlarge and require further treatment, which is typically surgery. So we do treat a lot of patients with Gamma knife radiosurgery, especially older patients with small or medium tumors, but they need to be growing in most cases for us to treat it. And the third treatment option, surgery. There's 3 different typical approaches. Two of them, we have potential to preserve hearing, and the other surgery, you don't actually, your hearing's lost because of the surgical approach, and that's called the translabyrinthine approach. But really, all three approaches, again, there's so many variables that go into it. I do think that's why it's important to see I think a team that treats a lot of acoustic neuromas. There's just a lot of different treatment options and thought process that go into it.
Okay, so what's recovery look like? I mean, what are some expectations people have versus maybe what's really going to happen? Are there any disconnects there?
Yeah, I mean, yeah, you don't know, right? I mean, you're decided you're going to have surgery, and then you'll talk to people. We have a great support group in Dallas and Fort Worth. They're just fantastic, and those are nice to go before treatment or even to help decide your treatment. But you just don't really know. But typically, I tell patients that after surgery, at least, they're going to have a lot of vertigo for a day or two. At UT Southwestern, we're going to start balance therapy with our therapist in the hospital, usually on day one, and that's going to allow the recovery to happen quicker. And I just tell patients to plan on taking 4 weeks off of work, and typically even I wouldn't even expect to drive for 3 or 4 weeks. And that's conservative for some people, but the vast majority of people by 4 weeks, they're going to be driving and back at work. And then over the next couple of months, they're going to really get their balance back. And most patients by the third month are really doing well. And back to pretty much living a normal life. Some small issues, depending on, were there any problems with surgery like the facial weakness and things like that. But I tell people 4 weeks is what you should expect to be off work and driving and things. Okay,
4 weeks. So no, that first weekend warriors going out and
no,
so within maybe a month or a little longer.
Yeah, a month. Yeah, we have. I like the patients that are motivated. They want to get better and want to get back to life. Those are the patients who do the best. But yeah, you're not going to feel like doing that the first week anyway. So, but 2 weeks in, I have some patients really begging to get back into the lifting weights and doing vigorous exercise. And really, 4 weeks is when most people can really start getting back to their life and more normalcy.
Well, we do, as expected, we do have some questions rolling in.
Right.
One of them we touched on briefly, but has your approach to treating patients with acoustic neuroma changed at all in light of the pandemic?
I think the overall approach is similar. I think, we can delay more surgeries, delay more treatments, maybe follow patients a little more. One consideration, we test all of our patients for COVID about 24 to 48 hours before surgery. But if you get COVID after a general anesthesia, a big surgery, there's a chance you may not do as well as if you didn't have surgery. So, if you've got a small tumor and you're considering surgery and you're not really trying to preserve hearing or anything, it's not a bad idea to delay that, especially, in Dallas, Fort Worth, our numbers have really picked up, although they're going back down. So, I do think we're delaying more surgeries. But I think the overall treatment's probably similar. Just unfortunately with acoustic neuroma, you can take your time and it's usually not going to create a problem to wait a few more months.
Gotcha. All right. So we've got one here from Sarmita. And the question is, does UTSW have a specialized vestibular rehab team in their outpatient PM&R department?
We absolutely do. An excellent team here, not only for acoustic neuromas, which we're very familiar with. They also treat, we see patients with dizziness. It's a big part of my practice, and they do an excellent job. And especially being at UT Southwestern, they're going to typically deal with a lot of patients that have very challenging vestibular problems. And so I really like to send our patients to our vestibular team here as the outpatient team, especially for that very reason. They're very good at helping complex problems. And of course, they see many of our acoustic neuroma patients. Not all patients need outpatient vestibular therapy. Many patients, 3 or 4 days inpatient therapy, they're given exercise to do, and a lot of times they can do these at home, but there are select for patients that struggle, and we'll plug them into our team here.
Gotcha. All right. Great question, Sarmita. Thanks for joining us.
Yeah.
It sounds like another question that came in, are there any long-term side effects that we know occur in pretty much every acoustic neuroma patient?
I think you'll always have, at least after treatment, there'll always be some degree of balance issues, and usually that's maybe if you do a fast head turn or a lot of visual stimuli, you still may get some dizziness because, when you remove a tumor, you have to remove the balance nerves on that side. Fortunately, our brain is very good at learning to use the other side. We were made with a bilateral system, so our brain's very good at using the other side, but it's not going to be as perfect as having two functional sides. So I do think that you probably always will have some, hopefully very mild balance issues. Headaches and things that can occur. That's not very common after acoustic neuroma surgery, but some patients do deal with chronic headache issues. Of course, if you do have a facial weakness, that is obviously something that can give you lifelong challenges and also things that you'll have to deal with and give dry eye and things like that. But I think many patients I see down the road, they're going to have some very mild issues, but most of them feel like they're kind of back at life and things are pretty normal.
All right, good to know. Good question.
Yeah, good questions. Yeah.
What's new on the horizon for acoustic neuroma, whether it's in treatment or preventive measures or after surgery? What can you tell us?
Yeah, I mean, one condition called neurofibromatosis type 2 is where you get acoustic neuromas in both ears. And we have a center here. We follow about 80 to 100 patients with NF2. It's very challenging because, you have an acoustic neuroma on both sides. You're probably going to lose all of your hearing eventually in most cases. And then you're also going to lose your balance function on both sides in most cases. And so with NF2 over the past few years and even before, probably over the past decade, we're treating that with a medication called Avastin. And we probably have about 12 to 15 patients on Avastin. And it's very successful at stopping the tumors from growing. And in some cases, preserving the hearing. We published a paper the past year showing that contributed to the literature showing that it does help stop tumor growth. And right now, it's only for NF2 patients, but there are other medications on the horizon. So there's a chance down the road we'll be able to treat some even single acoustic neuromas, maybe medically. Right now, that medicine has too many side effects probably to treat a patient with a single acoustic neuroma. But so some of those things are on the hopefully not too distant horizon, so medical treatments. From a hearing standpoint, if you lose hearing in one ear, you can do the hearing aids are much better, where you can wear a microphone hearing aid in the bad ear that takes the sound of the good ear. There's advancements in bone anchored hearing aids, which are very similar. And then we published a paper recently where we placed cochlear implants in patients with acoustic neuromas and very select patients, but that's also an option. So if a patient didn't have hearing and they had an acoustic neuroma in one ear that needed to be treated, you can consider a cochlear implant. So there's definitely, I think, newer treatment options for the tumors and for hearing rehabilitation in the near future.
Interesting. So we got a couple more questions coming in, and one of them is, what % of hearing can be regained?
You really can't regain hearing. With acoustic neuromas, if you have, let's say, a moderate hearing loss and you do a hearing preservation surgery, you're not going to be better than keeping the hearing where it is. Unfortunately, the hearing really never improves after treatment. With the gamma knife radiosurgery, the radiation treatment, I typically tell patients the hearing is going to probably be very similar to as if we didn't do anything. So oftentimes the hearing will decline over time, but unfortunately, the hearing typically does not improve. So you're not going to get better than where you are when you present.
Okay, that's too bad.
Unfortunately, yeah, that's too bad, but that's the reality of it.
All right. Well, so I know we've talked a lot about this. We didn't talk at the beginning about how common is acoustic neuroma. I know that NF2 is very rare, but what about the kind of the more general acoustic neuroma?
Yeah, they're not common. They seem common to me because we see a lot of patients with acoustic neuromas at UT Southwestern, our center, but in reality they're not common. Although if patients, acoustic neuroma patients, they'll start asking around and they'll know if friends of friends and maybe family, knows third cousins and things. That it's not that uncommon. It's one of the most common tumors in that area near the brain. But we're seeing it more and more often because of the more frequent use of MRI. So like I mentioned earlier, many of these tumors are diagnosed incidentally with MRI. And so although they're still not common, we still see probably more asymptomatic tumors from MRI. Okay.
So some of them are benign. So how do you determine, let's just leave this alone versus we really need to take action and consider surgery?
Yeah, good question. sometimes the tumors, again, they're very slow growing, and sometimes they don't cause any symptoms. So rarely patients may not know they have a tumor until it's very large. And if it's a certain size and too large, it's too large to treat with radiation therapy, and those patients would need surgery. And people say, well, what if I just let it keep growing? It'll actually press on the brainstem and cause spinal fluid pressure to increase, and can cause some serious problems and even death if you don't treat it. I mean, again, that's really doesn't happen in the 21st century because people get treated, but that's the reason we have to treat them when they're very large. Sometimes patients may have a small tumor and they have good hearing and they want to do absolutely everything they can to preserve their hearing. Then, we should consider a hearing preservation approach, which has a lot of nuances when you're talking about that tumor size, tumor location, age of the patient, size of the tumor. So that's a discussion that really have to look at a lot of factors. And then if the tumor, if you're observing a tumor, it shows growth and persistent growth, then we recommend treating it because that tumor is probably going to continue to grow. And then we talk about, do we do radiation therapy versus surgery?
Okay. We've got a couple more questions I want to get to, and I know you've got to get back to clinic. But here's one from Monica. Is there a way to stop the overproduction of schwann cells that make the acoustic neuroma? Can they be DX in utero or genetics?
I guess diagnosed probably, I'm thinking.
Can they be diagnosed in utero?
Yeah, what we call sporadic acoustic neuroma, where you have one pop up on one side. At this point, we don't really know of any genetic cause for that. If you have the bilateral acoustic neuroma, the NF2 condition, which is much, much less common, that is half of those are inherited and half of those are spontaneous mutations, which they can pass on to their children. But we're going to talk sporadic acoustic neuroma. There's probably not a good way, in vivo before someone's born to know if they're going to get an acoustic neuroma or not. Now, 100 years from now, yeah, maybe. Right? We don't know what's going to happen then.
That'd certainly be interesting.
Yeah, it would be, and I think medicine continues to advance, and I wouldn't be surprised if one day you can, tell somebody you got a 0.1% chance of developing this, or this. Once you have the acoustic neuromas, some of those medicines I was talking about, like that Avastin medicine, it cuts off the blood supply to the tumor, and so that's why it may be effective in stopping a lot of the tumors from growing. It doesn't kill the schwann cells necessarily. When patients stop the Avastin, for instance, a lot of times the tumor will start to grow again. But yeah, there's a lot of research going on to see, can we stop or deactivate the abnormal schwann cells? It's a great question, and there's research towards that.
Yeah, here's another one. It's more of a specific question, but a child with cystic fibrosis and has recurrent otitis media. Do you have any guidance on that?
That's just speaking globally, that's not uncommon with cystic fibrosis. The little cilia that help clear out the ear don't work very well with cystic fibrosis. And so it's not uncommon for patients to get ear infections. I would, most patients with cystic fibrosis have an otolaryngologist that they probably help manage some of their lung and their ear issues and their sinus issues. So I'd probably see I think a general otolaryngologist would be perfect for that.
Okay, good to know. All right, we've got time for maybe one or two more questions, and here's one of them. And how do we differ in our approach to acoustic neuroma here at UT Southwestern? I like to say, we otology and skull-based surgery, which is kind of with the team. It's a very small field, so we kind of know everybody around the country and know the different programs and our friends and colleagues in a lot of different programs. And I like to say at UT Southwestern, I think we take a kind of a mainstream approach, the same that an acoustic neuroma center would take. When I say a center, you're going to have an otologist, a neurosurgeon, a radiation oncologist. We have the vestibular therapist. We have a plastic surgeon that if you do have a facial nerve issue, that's very, very good. Audiology, rehabilitation audio. So we have this big team, and I think with programs a big team, I think we have a kind of a more of a standardized approach. I think we can offer some cutting edge things as well, like we do brainstem implants and things like that. But we're not going to do. I don't think we approach acoustic neuromas with some really kind of unusual approach that's kind of out of the mainstream. So, I think, and I encourage you to at least get an opinion at a center that does have it's actually a multidisciplinary approach. And there are many centers like that, but I think that's important. Okay, well, with this, you're doing so much virtual care and kind of management of treatment. Does that present an opportunity for others who may not be in the area to come to you for a second opinion?
Yeah, I mean, I think that's great. We see a lot of patients from, I have a lot of patients from Oklahoma, Louisiana, Texas, East Texas, West Texas, and typically patients have to come all the way out here. But yeah, you can, if you call our appointment line, we'd be more than happy to set up a telehealth visit. You just send in an MRI that you get locally, you can send in your hearing test, and we can really do the visit pretty much all over the phone. I don't have to. It's ideal to do an exam, but you don't really have to do an exam, and we can at least look at your films. And one unique thing that we do here at UT Southwestern is every month we have what we call a skull-based conference. And there's a entity called a tumor board where if somebody has a cancer, you present it in front of surgeons, oncologists, radiation therapists. This is kind of like that, and we present things like acoustic neuromas and other what we call skull-based problems that can be difficult to treat and complex. And at that meeting, we have over 20 people, which includes people like me, otologists, neurosurgeons, radiation oncologists, and other doctors. And so we typically present cases that there, especially when the treatment may be not straightforward. And we do that the first Wednesday of the month. So, if you had a conference with us, we could talk over the phone, and I can present you in front of that conference and let you know kind of the recommendation of the entire center. Yeah.
It's a lot of brain power in one room for the tumor board.
It helps because these are hard decisions, right? So I love having that as well.
Yeah.
I want to make the best decision for people.
So I know it's about time to wrap up. Is there anything else that you wanted to make sure that you shared during this chat, Dr. Kutz?
No, I mean, being diagnosed with any kind of medical condition, I've been through that, obviously my family and personally, and it's always, I think the scary thing is the unknown. I think one thing about acoustic neuroma, I think it's good to remember it is benign. It's not something that's going to spread your lungs and those sort of things. And there's really good treatment options. And I don't think you have to hurry into any kind of treatment options. I think getting information is good. I think seeing an acoustic neuroma center, if you want to get a second opinion, that's great. I think reading online, it can be helpful. I think also that can be harmful sometimes. You may read things if you don't have the medical background, you may read things that get kind of confusing and scary just because you don't understand all the nuances behind that. I think the Acoustic Neuroma Association is an excellent resource. We're sponsored with them and really have always appreciated what they do for patients. I mean, it's fantastic. We're actually going to just let everyone know on November 7th, we're going to have a virtual day dedicated to patients talking about acoustic neuromas, where members of the team are going to talk about different aspects of acoustic neuroma. We were going to do it on site, but because of COVID, we're going to have it virtually. So there'll be more information out about that. We'll put that on our Instagram and our Twitter sites. So you can decide. In our department, it's UTSWENT. And then UT Southwestern has other sites, like our Brain Institute also has a great site. It'll be on there as well. But I think the big thing, just it's scary diagnosis. And then, I think, again, get information. You've got plenty of time to make a good decision. And if you had treatment or having difficulty, I'd reach out to one of the centers. There's a lot of things that can be done that you may not be aware of. So that's kind of, I'd let everybody know.
Good plug for the new ENT social media accounts.
Yeah,
definitely.
we just started that a couple weeks ago. So
definitely follow them on Twitter and Instagram. They've got some great content going. We've got to wrap up this chat now, but I want to thank everybody for joining us. And this chat will be here on Facebook, and it's also on YouTube, so you'll be able to watch it there as well. It's definitely one of those trusted resources that Dr. Kutz was referring to that you can get good information from. So, Dr. Kutz, I want to thank you so much for your time and joining us today.
Thank you, Kristen, and thank you everybody out there. Stay safe.
Wear your masks.
Yes, wear your masks. That's right.